Joel Topf from Nephrology Times, and I've got Dana Rizk here. Is that a pronounced name, Rizk?
Rizk.
Rizk. Excellent. Well, thank you. You yesterday presented interim results on iptacopan in the APPLAUSE study.
That's right.
Iptacopan, the
Iptacopan.
CB, the complement
Factor B inhibitor.
Factor B in iptacopan. And super exciting results. And we're seeing just an avalanche of IgA nephropathy therapies come out, but it felt like APPLAUSE is somewhat different than a lot of the trials we've seen before. Do you want to kind of compare and contrast compared to NefIgArd and PROTECT?
Sure. So, iptacopan, the APPLAUSE trial is a phase 3 trial.
Yep.
The patient population is about the same. So again, biopsy-proven IgA, they have to be high risk for disease progression, so they have to have proteinuria of more than a gram per gram, and have to have a relatively preserved EGFR. They limited the timeline between biopsy and enrollment into the study.
So that's different, right?
That's a little bit different than some of the other studies. You could get into the study if your GFR is over 45. The biopsy could be up to 5 years old.
Up to 5 years old for the biopsy.
But if it's between 30 and 45 EGFR, your biopsy had to be within 3 years, so a little closer.
If more severe disease, they wanted to make sure it wasn't just all scar.
That's right. That's right. Although the biopsy findings did not dictate.
Oh, they did not dictate.
No.
Okay, fair enough.
Which
interesting.
Also nice,
and
that's
why
we
provide you information
data. That's right.
later.
So that's part of what we presented yesterday. So it's a different mechanism of action. It's the first complement inhibitor that has results at the phase 3 level in the IgA space.
Okay.
It's a factor B inhibitor, so it is inhibiting only the alternative complement cascade, which is the major part of the complement system that seems to be involved in IgA, along with the lectin pathway, but seems like maybe alternative may be playing a bigger role.
Okay.
And so the interim results were essentially the proteinuria, the primary endpoint, so the proteinuria results at 9 months.
So you have 9-month proteinuria results. This was a predetermined interim.
Correct.
Okay, and there's going to be a GFR addition.
Ultimately, that's right, at 2 years.
At 2 years, and you can't do it any sooner than that, right?
No.
You really can't. No, you really can't.
Yeah,
right?
yeah. Okay. It may not. It won't be reliable, essentially. So.
Right. Okay. So the proteinuria results. What was the top lane? How much proteinuria reduction did we get?
So relative reduction of about 38.5% compared to placebo. Absolute 43% reduction.
43% from the start.
Correct.
But compared to the placebo, 38. That's in the same ballpark as we've seen with some of the other IgA therapies.
And that, at least based on historical data, usually will translate into EGFR preservation.
Yeah, that's
so
right.
It's in that
in
range.
The pattern, we're seeing that.
That's right.
But one of the other differences was you presented data on hematuria, and I don't remember seeing that from PROTECT or NefIgArd.
So the hematuria data showed that in patients that had, so we divided patients at study entry into 3 groups. You could have no hematuria or trace, 1 to 2 plus, 3 to 4 plus. And as the study went along, there were more patients in the iptacopan group that moved to the lower levels of hematuria or even had no hematuria with time. So again, as the study progressed, less and less hematuria.
Okay, so my question is, since, like I said, we haven't seen that in these other studies, so who is thinking about hematuria as a biomarker? Should we be thinking of hematuria as a biomarker?
I think a lot of people look at hematuria and correlate that with inflammation in the kidney, which of course, it makes sense. The only reason in IgA we've been reluctant to label hematuria as such is there are people who have IgA who have isolated hematuria who do well for a long, long time. So the value of a little bit of hematuria is a little unclear. Certainly people that have high-grade hematuria, 3, 4 plus, that has to be bad news.
Right.
And then in clinical trials, it's really hard because you're relying on a dipstick that's done at the level of the site. It's very hard.
Is that how you guys are doing it?
You cannot ship all that to a central lab and travel around the sample around the world and then expect to see red blood cells that are still intact and so on and so forth. So some of it is the challenges of doing hematuria assessment as part of a large clinical trial that's global clinical trial.
Okay. So iptacopan is already licensed for PNH, is that
right?
Correct. And
recently, December 2023.
Oh, I did not realize it. It's very recent.
Very recent.
I guess my question is what can we take from the phase 3 trials for that disease? I would imagine stuff like adverse events we could probably is the dose the same? I guess would be the first question.
That's a great question. So adverse event in the PNH literature,
Yeah.
the only signal and the safety signal that the FDA required, of course, other than the infectious complication, which are the same with all complement inhibitors.
We'll talk about that in a bit, but I want to hear.
So the adverse event that made it to the drug package insert was hyperlipidemia in the PNH group. We have not seen any signal for hyperlipidemia. No. But we are, of course, monitoring as the study goes along.
But it's not. It hasn't shown anything. Anything on the adverse events that has shown up with you guys.
Nothing
so far?
that has surfaced that's beyond placebo or that's unexpected.
Now, you talked in their talk yesterday about vaccinations.
Yes.
You talked about a Neisseria vaccination for meningitis, right?
Haemophilus influenza
and
B.
H flu.
Not H flu, Hep B.
And Hep B.
Haemophilus influenza, and then strep pneumo was strongly. It's not a mandate, but it's strongly recommended.
Doing that.
Yes.
And do most of your patients do that?
Yes. Now, of course, there's wide variation in these practices across the world. So again, when you talk about the global study, certainly, some things are mandated and some things are
depending on the IRB, local IRBs in terms of how they address that. But essentially, it's all the encapsulated organisms
That's
want
correct.
to have coverage.
Yeah.
So, Dana, you are all over the place in IgAN. It's amazing. I mean,
it's a good time for IgA.
It's a good time for our patients.
Yes,
right?
absolutely.
And we're glad to have you in our corner. Can you give us a little update? I mean, you're also working on the APRIL inhibitors.
Yes.
Right? And how are those going along?
Very well. So the one that's kind of ahead of the curve, again, just in terms of enrollment, is sibeprenlimab.
Yep.
So this is the Otsuka-sponsored trial.
Yep.
The phase 3 has completed enrollment, and hopefully we'll see the proteinuria result, the 9-month proteinuria results pretty soon.
Like next week at ERA, or no, not that soon?
Maybe not that soon, but soon enough. And then there are 7
2 years,
right. Then of course the GFR data, and then there are other APRIL inhibitors that are behind. So zigakibart, that is Chinook, now Novartis, is again enrolling in their phase 3. And then we have the anti-APRIL BAFF inhibitors, so drugs that inhibit both pathways. And again, we'll see if one is enough. 2 pathways, different treatment for different patients.
Yep.
Again, that's the beauty of it, is having multiple drugs. So when your patient doesn't respond to one, you can actually pick something else.
Absolutely. Actually, I want to go back to the
Iptacopan.
Iptacopan for a moment. And I thought that Dr. Sparks raised a really interesting question yesterday in the session. And I just want to hear your answer again, for the listeners here, is that when you think about complement, it feels like the end of the long chain of events. It's the last thing that causes damage to the kidney. And does it make, if you stop it, that'd be great while the drug is on, but it doesn't seem like you're stopping the disease process, and that when the drug is off, you're probably going to be right back in the same point. I thought it was a pretty thoughtful question.
It is. So there is a lot of data, of course, about the activation and tissue damage from complement activation in the kidneys. So that hit 4 that you're alluding to. Having said that, I think we're still kind of unraveling what complements do in IgA and in other diseases. So as I mentioned yesterday, in the lab, when you put immune complexes, engineered immune complexes without complement, they don't activate mesangial cells. You need complement to even activate mesangial cells. So there might be, again, earlier roles for complements. We really don't know. And in the future, we might use these things in combination. So if we can shut off the production of immune complexes and prevent damage at the same time at the tissue level, maybe we'll end up using drugs in combination. So time will tell. But again, exciting times, and we should be embracing this phase.
Amazing.
That's right.
Hey, thank you.
We've come so long.
It's been awesome. Really appreciate this.
Thank you so much.